We are live.
Okay. Namaste, good evening. Welcome all to this EyeOpener Symposium on research and publications. So the idea of the symposium was to refresh our information and also seek help from the experts on the topic because often we find that on a daily basis we are doing so much of clinical work, but it is not translating into publications or research simply because of certain factors that come in our day-to-day working, like regarding statistics, regarding designing of the study or other such things. So the this module has been prepared keeping such things in mind. So I welcome all these experts and moderator Dr. Tolika Chauhan. I request Dr. Tolika to please introduce the speakers and we can take it from there.
So this is our agenda of today's program. So as we say that information is a thread to weave knowledge. In this era of information overload, if we reach clarity, that's the power of knowledge. So without further ado, I would like to introduce our first speaker, Dr. Apurva Ayachat. She has done her PG from MAMC, New Delhi, fellowship in Vitreoretina from Joshi Eye Institute. She received FICO from All India Ophthalmic Society in Vitreoretina and presently working as a consultant in Joshi Eye Institute, Hubli. She has 35 index publications and 6 book chapters to her credit. And she led UC as academic in charge for 2 years and conducted several academic programs for young ophthalmologists in training, education, and practice in association with AIOS. The faculty speaker of various state, international, and national conferences. Her competencies include complex VR surgery, macular imaging, and uveitis. Actively involved in teaching activities, research, and surgical training in Joshi Eye Institute. Dr. Apurva will be sharing her insight on planning of clinical study. So let's welcome Dr. Apurva for the first talk.
Thank you so much, Dr. Tulika, for that introduction. I'll be sharing my screen now. I hope all of you can see my screen.
Yeah.
Yes. So today I'll be speaking about planning types of clinical studies and planning your own study. So these are just a list of types of studies: the case control study, cohort study, cross-sectional, the randomized control trial, crossover study, case reports and series, and ecological study. Now let's look at case control study. Case control study is when the starting point is the disease. So the starting point is the deceased population. They are the tests, and the controls are patients without the disease, and they are the controls. So when the starting point is the disease and we look back in time to look at what could have happened as risk factors for the disease, it's called a case control study. So it's essentially a retrospective study. So the case control study determines the odds ratio. So you had the exposure. So what are the odds of getting the disease after the exposure? Odds ratio is the odds of getting the disease after an exposure divided by odds of getting the disease without that exposure. Basically, a case control study answers the question of what happened. So let's look at an example of a very famous case control study where the risk factors for development of AMD were studied. The study participants were Caucasians, older age, and all of them had bilateral AMD. So these are the cases. And then they were matched with controls for sex and age that the controls do not have the disease. So you can see that the starting point of this disease, of this study, is patients with disease, that is bilateral AMD. Now, when you look at what they looked at retrospectively the risk factors that could have caused bilateral AMD. And they saw that amongst so many thousands of patients, 6 major risk factors were brought to light. That is arterial hypertension, coronary disease, hyperopia, light-colored irises, lens opacities or previous cataract surgery, and coronary disease. And you can see that the odds ratio is much more than 1. So here. So this is a very good example of a case control study. It comes with its drawbacks that it has a recall bias. So maybe patients are more likely to remember the risk factors And there is a selection bias because patients, as opposed to the normal controls, may choose to enroll in such studies. So let's look at the cohort study now. The cohort study is a prospective study where there are two groups that are compared with different exposure status. So let's look at this example. Now there is an exposure and there is no exposure. So this is a cohort study where we look ahead in time in patients with exposure and compare it with subjects without the exposure. Now, since this is a prospective study, the advantage is that it can study multiple outcomes. Like you can see the Blue Mountain Eye study actually saw that in smokers, there was a higher incidence of nuclear cataract. There was a younger age of nuclear cataract acquisition. There was incident late AMD, and also there was higher mean values of the intraocular pressure as compared to patients without exposure or controls without exposure, where they had lower IOPs, less incidence of late AMD, and a later age of onset of nuclear cataract. So what does a cohort study do? It measures the relative risk. That is the probability of the disease in an exposed group divided by the probability of disease in a non-exposed group. So it answers the question of what is going to happen. Now, this is a very nice study of incident myopia in Singaporean children, where they did a 3-year prospective cohort study in school children aged 7 to 9 years without myopia at baseline. The main outcome was incident myopia. And they saw that the relative risk of having myopia was higher in children with 2 myopic parents versus having no myopic parents and children with higher IQ. So what this study said was there was essentially a link between parental myopia and IQ scores and subsequent myopia development. It comes with its own drawbacks because follow-up in a cohort study may run over a very long time, can be decades, as shown by the British doctor study about smoking and lung cancer. It is this very time-consuming and expensive, and there is a risk of attrition. Also, over the period of the study time, subjects may change their preferences, their lifestyle, etc. Excuse me. So we saw that the cohort study is retrospective, but I'm so sorry, prospective, but can it be retrospective? Yes, it can be retrospective, wherein a retrospective chart review can be done in a cohort. So when we look at this study, where it studied the adverse event rates in the retrospective cohort study of safety of pediatric soft contact lens wear, now this is the cohort they're looking at, where children between 8 and 12 years old were fitted first with a contact lens. There were 963 children. And with a chart review in the later years, the adverse events were were looked at. And they found that inflammatory adverse events were seen at 0.66% per year, papillary conjunctivitis at 0.48% per year, and they saw microbial keratitis in only 2 children. So this is an example of a retrospective cohort study where there is a cohort which is studied with a chart review about what happened in the future. In the future of 2 to 3 years after wearing a contact lens. So both of these are in the past, please mind that. So this is a cross-sectional study. It analyzes data at a single point in time. This is cross-sectional data and it tells you the prevalence of a certain disease. And it answers the question about what is happening. So we saw about case control study, which answers the question, what happened? A cohort study, which answers the question, what is going to happen? And a cross-sectional study, which answers the question, what is happening? Now coming to the most important, that is the randomized control trial. This studies the causation of a certain disease or a treatment of a certain disease or a diagnostic test, wherein the subjects are assigned to either the test group or the control group. I'm a VR surgeon, so for me, the most interesting ones are where they have tested various intravitreal pharmacotherapy agents. The test group receives the molecule and the control group receives a sham injection. It is important to know that both the test and control group should be as similar to each other as possible. They should be matched. The group should be similar in gender, disease, education, geography, ethnicity as far as possible, like this little illustration here. This is because you want to attribute the success to the new potential treatment to the extent possible without confounding factors. Now, they can be blinded. A single blinded study is when only the participants are blinded. Double blind is when both the participants and the researchers are blinded. And the triple blinded is when even the data analysts are blinded. So this is a very nice flow chart. So did the investigator assign exposure? If yes, that means the investigator is intervening. It becomes an experimental study. Is there randomization? If yes, it's a randomized controlled trial. If it's not randomized, it's a non-randomized controlled trial. Now, if it's not an experimental study or there is nothing that the investigator is doing in terms of intervention, then it becomes an observational study. If there is a comparison group, it becomes an analytical study. Now, let's look at the direction. Like we know, if the exposure is known and the outcome is unknown, it's a prospective cohort study. If the outcome or the disease point is the starting point of the study, and you want to study the exposure retrospectively, it's a case control study. And if you want to know both at the same time, it's a cross-sectional study. If there is no control group, then it's a descriptive study. This is a crossover study, which is essentially a variation of the randomized control trial, where group 1 and group 2 receive different medications, and after a washout period, they are crossed over to the other medication, as in group 1 will now receive medication B and group 2 will now receive medication A. Case reports and series, they just document one patient or few patients' responses to disease or treatment. Now, how to plan the study? The main point is how to formulate a research question, planning the clinical study and executing the study and analyzing the study. Now, the main problem comes in how do I make a research question? How do I conceptualize a research? So first, these are some general pointers on how to conceptualize. You have to read a lot. There's a lot of detailed literature search that is involved. When you attend more talks and webinars, you realize what is not known and discuss the subject area. So which aspects of your discipline interest you most, and what have you observed that you have questions about? And what articles have you read that have raised questions in your mind? So this e-talk is something I learned from Dr. Sabyasachi. Most of the things I've said so far is also some things I've learned from him. So because of his research academy. So basically you write your email address and sign up for the e-table of contents of a particular journal, and it sends you emails whenever there are new issues of the journal. And that's how you keep abreast of the latest in your field. So originality can be of a novel surgical technique, a novel clinical or imaging finding, new drug, new mutation, many layers of originality. Now, what are the gaps in the literature is something we have to see. What is not being looked at? What method is not being done? Who is not being studied in terms of population and who is not being compared? So the types of questions are background questions, which are very broad, like what, which, for example, what are the treatments of PCV is a very broad background question. But when you get down to the specifics, something like in a patient of PCV with pachychoroid, will adding photodynamic therapy to intravitreal aflibercept reduce the number of rebleeds is a very specific question. So how do you frame a research question is broken down into these 4 parts, which is the PICO. That is P is for population, I for intervention, C for comparison, and O for outcome. You can add 2 T's, wherein it becomes the type of question where you're what you're asking, whether it's a diagnosis question, therapy question, prevention question, or the type of study. I'll just come to the examples. Now, this is one example where the P is population of patients. Who do you want to study? Is patient with chronic CSC. What is the intervention? That is I, subthreshold micropulse laser. Who are you comparing it with, or what are you comparing it with? Photodynamic therapy. And what are the outcomes? Final visual acuity, the outcome that you want to study. So this becomes an example of a therapy question because you're comparing 2 therapies. So the best design for this would be a randomized control trial. Now coming to the next example where patients with chronic CSC, you want to see whether obstructive sleep apnea is there as an exposure, and you want to compare it with people with no sleep apnea. The outcomes would be number of recurrences. So this is an etiology question, and the best design for this would be case control study. So about aims and objectives, they have to be very specific and smart. This is the mnemonic. The mnemonic SMART is for specific, measurable, attainable, relevant, and time bound. So you have to decide the study design and know the ideal study design. For example, like I showed in the previous examples, for a therapy question, the best design is an RCT. For etiology questions, the best design can be a case control. Cohort is a little unrealistic, or it cannot be done in a residency of just 3 years. And it must be feasible. For example, you want to study retinal sensitivity, then you can't do it if your center doesn't have microperimetry. So this is something I borrowed from Dr. Sengupta. This is the levels of scientific evidence. And this is why you need to decide your study design and which study design would give the highest level of evidence for what you're trying to study. So the RCT is one of the highest levels. Above that is the meta-analysis and clinical practice guidelines. The lowest evidence in animal and lab studies, case report, followed by case control and cohort studies. So how do you want to collect data is also something to be planned. Is it going to be by surveys, interviews, by examination, or any other outcome of variable of interest? Then there are ethical considerations, which are very much a big part of your plan. We have to get the EC approval, informed consent, ensure confidentiality, minimize potential harm to the patients, have to get it approved by the institutional review board, and it has to adhere to good clinical practice guidelines. Others are budgeting, risk management, whether the protocol of the study is being properly documented, whether the protocol is being adhered to, has to be checked at frequent intervals, and the study has to be monitored. It's not like you just write the protocol and then you're not looking at what is happening and you leave it to somebody else to monitor it. And there are a lot of roadblocks in any study, and it has to be identified by periodic checks and have to be remedied periodically. So if you fail to plan, you plan to fail. Thank you so much for the opportunity. I'll stop sharing now.
Thank you, Dr. Purva. That was wonderful talk. And I would invite people to ask questions if there are any. Just a moment. I have. So people who logged in can ask questions. We have a question round by the end of the webinar as well. But if somebody has specific questions as far as the talks are concerned, please post your questions in the chat box so we can ask the questions. So it seems there's no question. So if I summarize your talk in 2-3 sentences, then what limitations we are facing in planning a study? It's poorly defined objectives, sampling issues, insufficient data, improper statistical method, and the confounding variable. That's what this is my takeaway from your talk, that why we are not planning well. So your talk is definitely helpful for us. Dr. Sagarika would like to ask a question. Ma'am, can you please go unmute and ask your question?
Thank you so much for the talk. I think that was really brilliant, because there's the initials of any kind of research subject. Now, as you have very correctly pointed out, that, when we are having, so when we have, for example, students who have come only to us for a very, very short while, let's say, for example, 2 years. In 2 years, initially when they come, as you said, they have to read a lot. So I think the one thing that the guides should know is that what is it that they want their students to do. But it takes a long time. So initial, let's say 2 to 3 months is spent in just reading. After that, formulating a plan. So could you give us examples where it is easy to do? For example, it is very difficult to find a research question which people have not looked at. So how should our research be for students who are absolutely new to the subject? Are we looking at determining something new, or are we just reinventing the wheel?
Yeah, that's a great question, ma'am. I'm just going to assume it was directed at me.
Yes, yes.
Yeah, okay. Thank you so much. So, maybe this is our style of working, but I think it is the responsibility of the thesis guide or the mentor to assign the topic to a student, because these students are absolutely raw and they have just entered ophthalmology. They have had no exposure in ophthalmology during their undergraduation. So I think the onus is on the guide to assign a topic, to encourage them and to find out whether they are interested in that particular subject, and then slowly nudge them in that direction. It is very difficult for a fresh resident to be expected to come up with a research idea about the fundamentals of which they do not know. So any other answers?
No, what I was basically asking is that even for the guide, it's very difficult because, as I said, are we going to, during a particular thesis topic which is being given, are we trying to find something new, or are we basically teaching them the research method, how to collect data, how to analyze it, what is, like, for example, whether it's a cohort or whatever whichever type of, because you can't do a prospective study, which is very difficult. Retrospective is maximum that you can go for, but which, so should it be that, we guides just look at this point that, all right, we go ahead and we don't reinvent, we just reinvent the wheel, just find out something which perhaps might help in adding to scientific knowledge.
So definitely it should be novel, ma'am. I don't agree or I do not encourage reinventing the wheel. I think every thesis topic should study something novel, and there is always something new to be discovered. And I have also seen that in the process of study, when you're looking at various variables, you realize that something very unique is just jumping out of your Excel sheet and never been studied in the past. So that has been my experience. That we have come across novelty like quite, it has become novel serendipitously because we saw something in the Excel sheet that was, because we are seeing each variable with a unique perspective, and we sometimes find new variables to study. I think every thesis topic should be assigned with great care. It should not be talking about whatever has been done already. I think the most basic thing the question has to be answered is what has not been done, which population has not been studied, who has not been compared, or
Yeah.
it need not be which drug has not been used, because getting a new drug is something which is inconceivable for most of us. So at least the other questions can be kind of new.
Yes.
Thank
But
I-
Dr. Sagarika, I have a take on this. Basically,
Yeah.
what Dhruva says is idealistic. Of course, that is how it should be done. It may not be possible in all situations, mainly because of lack of clinical material and the time that is available and the equipment that are available. In a medical college situation for a postgraduate or a DNB institute, it may not be possible to seek new knowledge all the time. But if a mentor has a pipeline of studies, that means that you are studying one particular aspect of glaucoma and you want to go quite deep into it, and you have a pipeline of studies. One aspect can be given to one resident, and in the next year, maybe the next sequential aspect can be given to the next resident, and so on. Ultimately, you'll complete that jigsaw puzzle, something of that sort. So,
Thanks. Yeah.
that is
Exactly.
practical in your situation. Of course, novelty is ideal. It may not be possible.
Yeah, but okay. We would like to have novelty, but as I said, it's very tough.
Sunny may have.
We have few more questions. Would you like to discuss these questions by the end of the webinar, or would you like to take the question right now?
I think you can go ahead if quickly, because that will complete one topic, then we can go to the next.
Okay, fine. So question directed toward Dr. Purva, that how can we determine the reliability of an article on different platforms? This is asked by our DNB student. So Dr. Purva, can you please help?
So, Ishita, that's a very nice question. Actually, the reliability of an article is based on how good the journal is. If the journal has a very high impact factor, it is very reliable. All articles go through a very rigorous peer review process where there are more than 3 reviewers assessing the quality of the manuscript and the quality of the study that has been submitted. So if it is a high impact journal always invariably is PubMed indexed. So PubMed indexed journals with a high impact factor are pretty much reliable. And if you feel there is some, if you have questions about the veracity of the study, then you can in fact plan your own study, which could give contrasting results.
Thank you, Dr. Purva. Now we're moving to the next speaker. I'm going to share my screen here. And yes. Okay. Why it is not? Just a moment.
It's visible, ma'am. Please go ahead.
Yeah, but there's something blocking my view here, so I'm just trying to just stop sharing here. Yeah. So Dr. Sabyachi Sen Gupta is a diploma from JIPMER and DNB from Arvind Pondicherry. He's a research and clinical fellowship from VR from Shankar Netralaya, research fellowship at Wilmer Eye Institute, John Hopkins. Currently a vitreoretina surgeon practicing at Future Vision Eye Care, Mumbai. Ex-associate editor of Indian Journal of Ophthalmology. Awarded the McCartney Prize by Royal College of Ophthalmologists in London, 2010. First ever non-British national to receive this award. Published 100 plus papers in index peer review journals, included in top 2% of global researchers list by Stanford University for 2021. And the most impressive is the founder of Sen Gupta's Research Academy, a one of its kind portal offering e-learning lectures on research methodology and services for manuscript preparation. Dr. Sen Gupta's work has significant impact on research world of ophthalmology. He will talk on statistics and data handling. Over to you, sir.
Thank you so much, Dr. Tulika, and thank you to Santosh sir, as always, for giving me this opportunity to come and interact with all of you. So let me quickly share my slides. So I have purposefully omitted, that the piece which was part of the flyer, which said that that it should scare you, because trust me, without statistics, we will be nowhere. Say just for example, the efficacy of a new vaccine is 90%, and another study says the efficacy of a vaccine is 92%. Now, how will you choose? Is this better or that? Right? So, but before that also, just put in perspective these percentages. These are all numbers, right? So what we're really doing is visualizing whatever we have with the starting point of numbers, isn't it? So incision 5 millimeters, incision 2 millimeters. We're all talking about numbers. So we are dealing with numbers all the time. What we're not really doing is making sense of a lot of those numbers. So hopefully I'll give you some ophthalmic examples, and we'll make sense of some of the published literature together, some of my financial disclosures, but nothing relevant for any of today's talks. So I really hear this quite a bit, and I travel really extensively all over, teaching some research and also retinal diseases. People say, "Oh, I'm really busy, I don't have the time." And what do I hear? I hear, "Oh, I don't have that much intent, and I don't really have the drive. I'm too busy with my clinical work." So just try and introspect a little bit, and think whether these are interchangeable or not. And perhaps you might feel that, oh yes, if I have a little bit more intent, I could do more. And India is really the hub of a lot of data, right? So there's so much potential all over the place. We know we have a lot of data with us. And in the future, data is going to be power, it's going to be the currency, it's going to be everything. But then, we are not, unfortunately, not looking at it that way. We are not leveraging our data. We are not leveraging the numbers to learn new things and to teach the world. We are still dependent on, pretty much everything that comes from the West, right? There are some outliers like Santosh sir, who has done so much work on retinoblastoma, but then there are so few and far between that, we can't really Now, you can't tell a child, you should become like Sachin Tendulkar, because it's just almost impossible. So similarly, but the foundation has to be starting from residency itself. Remember, data is, whatever you want, you can leverage. You want money, you can leverage currency. You want power, you want, whatever you want, you can just leverage. But then you need to get started. There's a quick stat, quiz on biostatistics that, I created for some other lecture, but then I thought we won't go enough into this and do it. But then, it's a recording. You can actually take a look at it, even at a later date, and you'll discover what you already know and what you might know. And if you go through this lecture, hopefully you'll be able to answer all the 10 questions, yeah, pretty accurately. So what you're looking at, data analysis and interpretation. Before we go ahead, again, this visualization is really important, right? So, when you are looking to do a difficult surgery on the next day, the previous day, we are continuously thinking about the steps that I'll do. Oh, there is oniodialysis. I'm going to make an incision there, or there's a retinal tear here. I'm going to make up a 23 gauge port there. And I'm going to start with this. I'm going to do that. And what we're really doing is replaying all the steps in our mind before we actually go ahead and do it, right? So we are visualizing. But when we look at numbers and an Excel sheet, do you visualize what kind of graph is going to come out of this? What kind of tables and figures are going to come out of this? We don't, right? We are simply not tuned that manner. I mean, as humans, we are not tuned to look at it like that. But what I'm really trying to tell you is, when you look at data, you need to, start looking at how you will be able to present it as well. A quick note on visualization.
Visualization, the recreation of images, sounds, and environments before it has happened, is one of the most powerful skills in the world. A very powerful meditation and mindfulness practice, visualization has been used for centuries to help prepare the mind, the body, and the consciousness for upcoming challenges, situations, and circumstances. Some of the world's greatest athletes use visualization as a way to prepare for big games, the big day, musicians for their new concerts and tours, and CEOs for their very important meetings.
And so why should CEOs and musicians use it? Why not physicians, right? So think about this a little bit, and then we'll get in the nitty-gritties. Another quick book that if you want, it's all based on visualization. And the first one is The Power of Your Subconscious Mind. The other is Think and Grow Rich, and these have been updated several times and they are very much in sync with today's times. And remember, with visualization without any execution is just hallucination, right? So this is Edison and none other than, no one else, right? So if you are actually looking to do something and visualizing but not executing, it's pretty much, gone down the drain. So overall, the roadmap to publish really starts from the idea, and where from Apurva has already given you some insights, like subscribing to e-table of contents. And somebody was asking, how do I get ideas, right? As thesis guide is difficult, but you have to be on the prowl, you have to be on the lookout. Every conference you go, there are so many posters, papers, free sessions. If you attend some of those instead of sitting in lectures which are going to repeat the same thing over and over again, trust me, you're going to get ideas, right? So getting ideas is a habit. It is not really something that you can just do one day because you have a thesis student in front of you, right? You need to have a pipeline, or you need to have a whole pool of ideas. Generally what happens is a student comes, a guide will say, okay, go and get some 5-6 ideas and I'll choose one from one of them. Imagine what will happen, if the student comes and the teacher say, and the guide says, oh, here are 5-6 ideas. Which one do you want to do? So it's a whole topsy-turvy, it's like flipped, everything is flipped. But then that really is how it should be, right? So let's try and get towards that. So the idea, then comes the design, which Apurva has talked about. I'm going to talk a little bit about the statistics, and then, Vanati ma'am and others after me are going to talk about how to write. So we are pretty much covering all of these today. So let's talk a little bit about statistics. So we'll start with a question, and we'll come back to this later on. So what you're trying to understand is this statement. You will see it in a lot of retina papers and many others as well. So I'm going to read this statement. It says the CMT is central macular thickness. The central macular thickness reduced from 480 plus or minus 130 microns to 320 plus or minus 80 microns with aflibercept injection, and from 489 plus or minus 140 to 340 plus or minus 90 microns with ranibizumab injections at 3 months follow-up. Right? And so the ones in red are one drug and the ones in blue are the other drug. Reduction in macular thickness in the two groups was comparable without any statistical significance. P is equal to 0.63. Right? So if I were in front of you and I would ask you to raise hands, as to how many of you have seen statements like this. You can interchange this with anything like intraocular pressure or like visual acuity or like, so many others, corneal thickness. This is across the board. So most of you would have read these, and if you are very fresh into residency, you will read these statements. So how do you actually make sense of this is what we're actually going to try and, just to give you that perspective, instead of just going ahead and saying, oh, this and that, use the t-test and use this test. This is the perspective, and let's try and just understand how to interpret this. There's a lot happening in the back end, and we'll get to that. I'm going to show you another scenario, and we'll try and interpret that as well. This is about causality association. So what comes first and what comes later? And if somebody compares the lipid profile of 50 patients with glaucoma and 50 age-matched controls, right? You're starting with a group who have glaucoma, say a glaucoma clinic, and other who don't have glaucoma. They're age-matched controls, and show that 60% of glaucoma versus only 15% in the controls have, say, dyslipidemia or any other disease. Can you conclude that dyslipidemia is a risk factor for glaucoma? You have to really concentrate a little bit and think about this. So 60 out of 100 glaucoma patients have dyslipidemia, and 15 out of 100 patients in the age group, age-matched control who don't have glaucoma at present, they have dyslipidemia. Now, can you actually attribute that glaucoma to dyslipidemia? Or in other words, is dyslipidemia associated with increased risk of glaucoma? So do you think this is the right study design to answer the study question? Or do you really think we should start with dyslipidemia, have a cohort with dyslipidemia and another cohort with dyslipidemia, without dyslipidemia, and follow them up for whatever, 5, 7, 10 years, and then see how many develop glaucoma in that dyslipidemia gang versus the non-dyslipidemia gang, right? And then you will be able to say, oh, the numbers won't be that high, right? But you're able to see the importance of that kind of study design, right? So causality association, don't say this causes that. Don't say vaccine causes CRVO or COVID-19 causes CRVO, because it's not true. It's a belief, there are a lot of theories behind it, but then a lot of very large scale studies have clearly shown that CRVO or vascular occlusions are not related to COVID, are not related. Though we know that, COVID causes a lot of these pathogenetic changes and, increased counts, and it's a prothrombotic state, but it still doesn't cause CRVO, right? So we are going to try and understand a little bit of these things. First is one drug better than the other in terms of whatever we're looking at? Second thing is causality association. Let's get to this. This is a book which pretty much has all of what I'm going to talk about now. And this is a QR code to download that ebook. And you can actually come back to the recording and look at it later on again. But this will give you pretty much everything that we're going to discuss going forward. If we understand how to interpret these statements, let's understand that data is observation that comes from an experiment or research, and variables are each set of observations in the data set. So you'll measure somebody's visual acuity, intraocular pressure, corneal thickness, cataract stage, and then what is the retinal thickness, and so many other things, endothelial counts. All of these you're going to enter into Excel, where each patient has a row to himself or herself, and all of these are columns. So each column in an Excel sheet is a variable. Age, gender, BCVA, OCT thickness, number of injections, what have you. So this is a very basic way to look at statistics, and we're going to build on top of this very baseline. Now, variables are of two types. One, it's a continuous variable or a categorical variable. And let's not go too ahead of ourselves. Let's understand what is a continuous variable. It's also quantitative. It's like if you place it on a measuring scale, you will get a value. You can quantify it. A variable that can take any different values from the lowest to the highest scale. So if you look at age, it could be like 1 hour. 2, it could be like 110 years of age, right? So literally so say intraocular pressure, say for ophthalmologists, it could take anywhere between 0, sometimes it's 0, IOP is 0, to anywhere about 60, 70, right? Beyond that, we can't even measure it. So, they have a unit to it. Age will be in years, right? So BCUA will be in logmar units or Snellen's equivalents. IOP will be in millimeters of mercury. Macular thickness or retinal nerve fiber thickness is going to be in microns, right? So these are all examples of continuous variables. Let's look at what are categoricals. So categories, they are categories or baskets. You can classify people and put them into one of 2 baskets or one of 3 baskets, depending on what you're actually looking at. So you're looking at the quality of that variable. right? So continuous can't be categorical. Categorical can't be continuous. So things are grouped together. And right, so gender is a categorical variable, male and female. You don't have a unit, right? And it can be any, something else other than male and female, like I don't want to say, or I don't want to disclose, or neither, or whatever. Nowadays there are a lot of these coming up, but still there will be 3 or 4. Based on your definitions, you can say success is either yes or no. You can say type of macular hole closures is type 1 or type 2. Or types of neovascular membranes is either classic or occult, based on the definition that you used to use in the past, right? Type of injections, type of injury, it's either open globe or closed globe. It can't be anything else, right? So these are examples of categorical variables. Now, if there are only 2 categories in that, we call it binominal, and that is by far the commonest. The second type of categorical is ordinal, where there are more than 2 categories, but they are in an order: complete success, qualified success, and failure. The commonest ordinal variable which we use pretty much every day is diabetic retinopathy, where we say mild NPDR, moderate NPDR, severe NPDR, very severe, then early PDR, high risk PDR, advanced diabetic eye disease, and so many other things, right? So there are 7, 8 possibilities. Somebody may have mild, somebody may have moderate, right? So that's a variable with more than 2 possibilities, but there is an order to it, isn't it? So we call it ordinal, order or ordinal. And third is multinomial, when there are more than 2 possibilities, which is very possible, in any way, whatever variable you want to look at, but then there is no order to it, right? So you say, I have given these 3 injections in a study, right? So say Avastin and Lucentis and say Eylea or something like that, right? So, or, say I'm measuring 3 IOP drop in 3 different IOP lowering medications. So now that there are 3 types of medications, 3 categories, but then they are not related to each other. There is no order to it. So now these are called multinomial variables. Quick exercise. Let's, try and understand whether it's a continuous or a categorical. Height of subretinal fluid in CSR, central serous choroidenopathy, that's in microns. That's a continuous variable. Presence or absence of hard exudates in DME. You could say it's a categorical variable, right? You can also actually count number of hard exudates. Actually, there are some studies which have done, who have counted how many hard exudates you can see: 5, 10, 15, 17, 20, 30, 40. Now, that is not continuous, right? That is not categorical. That is continuous, because it can take anywhere between 1 and 2 to like 50, 70. So, based on what you are actually recording, you will get continuous or categorical variables. Say response to IVTA, it could be either good, fair, or poor, based on how you classify it. Now, this is an example of more than 3. There are more than 2, and there is an order to it. So this is an ordinal variable. Number of days of follow-up of a patient is an example of a continuous variable. You need to understand that making an Excel sheet is very crucial. It's many times we send an Excel to the statistician and they just sit on it, or they just don't send it back to us. And whenever they send something back to us, it's all gibberish and we can't understand what they're saying. That's the primary cause is your Excel is poorly done. So this is a QR code. Again, we don't have a lot of time to teach you how to do Excel sheets properly, but then as residents, you have to understand, or, somebody who's beginning out, you have to make good Excel sheets. One quick rule is you can't put alphabets into an Excel sheet, except for the first row where you say age, gender, this, that. You can't put alphabets. It will not be useful. It can't be analyzed. When you think about the last 4 or 5 Excel that you made, you will have an aha moment. You said, oh no, I have put so many all over. So you can't say 5 years. Just say 5. You can't say 5 YEARS. And immediately below that, you can't say 5 months. Why? Because they are different units. No. Same unit, it should be the same unit. Other, again, common mistakes is 1, 2, 3. I've put, oh, this patient had all 3. So I've put 1, 2, 3. But again, that is not utilizable at all for analysis, right? So you have to make good Excel. Once we are done with the Excel, you have to try and describe each variable. Let's not look at how they interplay with each other. First, look at each column on its own. So when somebody comes to bat, or when you're watching a cricket match, a player is coming into bat, say Rohit Sharma, even if he is famous and the whole world knows him, they'll still show his photograph. They'll still show his name. They'll still show how many matches he has played and what is his average and strike rate and so many other things. So they will describe him first. Then they will see, then we will see how he plays and, whether we win the match or not. So again, same thing we're doing here is we're describing each variable on its own, and then we will see how they interact with each other. So this is called descriptive statistics, right? So how do you again describe continuous and categorical variables? You describe continuous variables by their mean with standard deviation, or you you talk about their median with interquartile range. And it's like, you're introducing a friend, we are almost humanizing that variable, right? So you're introducing a friend to somebody, you will say, oh, hello, this is Mr. IOP, and then what? You will talk about your friend, no, oh, we were together in school, and, you will talk 3-4 sentences. Same way, you will say, oh, this is Mr. IOP. His mean is so-and-so. His standard deviation is so-and-so. And, his minimum and maximum values are so-and-so. And there are a few outliers in his pants or, whatever like that, so outliers are extreme values, right? And you show them using box and whisker plot. We show you, right? And categorical variables are described as proportions or percentages. So he's Mr. Injection. Out of that, or he's Mr. Gender. Out of that, 60% were men and 40% were women. That's about it. You can't talk anything more about categorical variables, right? And they are best shown with bar diagrams. This is an example of a box and whisker plot. This is only for continuous variables. This is pre-operative IOP at 6 weeks and IOP at last visit for a particular study. Now, this box and whisker means, again, there is a box in the center. The center line in that box is called the median value. Here it is, say, about 17 or 18 millimeters mercury. This is IOP. The 50th and this is the 50th percentile or the median value. The bottom is the 25th percentile. Upper part of the box is the 75th percentile. Then you have these whiskers. These are whiskers are nothing but mustaches of a tiger. They are called whiskers, right? So these are really looking like whiskers. So the upper line is about 90th percentile of the median value, and the lower is 10th percentile. And then you have these numbers which are very away from the central tendency, right? So here somebody had an IOP of about 55. Another had an IOP about 56. But when you're doing a glaucoma study, it makes sense because there could be some like that. But if this is a cataract study, these are outliers, right? There's something wrong with them. You have to go back and see why it is like that. Why did somebody with 55 IOP get recruited for a cataract study? Is it actually 55 or is it 15 and somebody has made an error in entering? It is very possible that would be the case, right? So depending on the context, you need to understand, are there any outliers in every continuous variable that you're looking for? And then what do you do with that? Do you want to keep them? Do you want to discard them? That the choice is yours. Discarding is never a good idea, right? So, but then you should at least know what they are, right? So these are outliers. So this is a continuous variable. There are, you can make very fancy box and whisker plots, something like this as well for different, visits. Say this is baseline and, visit 1, visit 2, visit 3. And you can make, here you see there's a lot of variability which is shown, not just 1 or 2 dots. All of them are shown, and this is far more visual. People, you will see this more in CNBC or, or one of those, Bloomberg channels rather than in medical papers. But then you can also do something like this. Now let's look quickly at analytic statistics. So now we have all the players. We know all the players in both the teams or in, in general. Now let's look at how they interact. So how do all players interact with each other as a team? And what is the final goal? Do they win, right? So our final goal is to actually prove or disprove our hypothesis, the study hypothesis, right? But then for that, we need to see how one variable interacts with the other. So there are 3 main ways they interact with each other. One is difference between variables, right? So is the mean age of, say, one injection group different from the mean age of another injection group, right? So there are differences between variables, right? So there are 2 groups or 3 groups or whatever. We want to see whether one group differs from the other group significantly. Second is called correlations between variables. That is, if one variable increases, does the other also increase? So if baseline IOP is high, does that mean final IOP is also very high? If baseline vision is poor, does that mean final vision is also very poor? You've heard about these things, right? So, baseline vision is the best predictor of vision in trauma cases. So there are reasons for that, but then these are called correlations. And then third are associations that I showed you before, right? So you are talking, so this is causality, right? You're talking about one coming first and then the other happening, right? So there are ways to analyze this using statistics. Difference between variables is analyzed using, again, whether it's continuous or categorical. So you're understanding why we need to differentiate whether it's a continuous or a categorical right from baseline, because everything depends upon that. When you have continuous variable and it is normally distributed, right? So that means there are not too many outliers. What we do is the student t-test when there are 2 groups, right? So there is an aflibercept group and then there is a ranibizumab group, and we are looking at their mean thicknesses before and after, and we are actually trying to compare across the groups. Normal distribution means there is not much variability, right? So that really means the standard deviation is relatively small. Okay, so if the standard deviation, listen to this carefully. So if the standard deviation is less than half the mean, right? So it is normally distributed usually. If the standard deviation, many times you will see IOP is 10, is 20 plus or minus 18 or something like that. Right? So, or you will see BCVA is 0.5 logmar plus or minus 0.6. Now the standard deviation is bigger than the mean only. Right? So that means there is a lot of variability, isn't it? There is a lot of deviation basically. So there is a lot of variability there. So that is not normally distributed. If it's normally distributed, we use the student t-test. If it's not normally distributed, we use something called the Wilcoxon rank sum test. And there are more than 2 groups, we use something called the ANOVA. Right? Everybody's heard about the ANOVA. I hear a lot of people telling me to do an analysis and say, will you be using ANOVA? Somehow it's like, I think it sounds like Innova, the car, and therefore a lot of people talk about ANOVA, but then we don't use ANOVA very often. That's because there are not more than 2 groups. Mostly we are looking at this versus that. ANOVA is analysis of variance, right? So, just remember that we don't use ANOVA very frequently, but then, you need to know which test to use when. If you are looking at categorical variables, that is, are percentage males more in one group compared to the other group, then we use something called so we are looking at proportions here. So we use the chi-square test. CAT for chi, categorical chi-square, very simple to remember. And if the numbers are very small, less than 5%, say endophthalmitis in one group is 0.7% and the other group is 0.8%. Now these are really small numbers, and chi-square test is, it's based on certain foundations, which doesn't allow for comparisons below 5%. So there we use the Fisher exact variation of the chi-square test, right? So based on this, this is there in the book, in the ebook that I showed you before. So what you have to look at is that what is the type of variable, how many groups are there, is the distribution normal, and then decide what the statistical test to be used is. The outcome that you are going to get is called the p-value, right? So when you do a test, when you apply the statistical test, say the mean age of one group is 45 plus or minus 8. The other group, or say let's take IOP, say the mean IOP is 15 plus or minus 3. The other group has a mean IOP of 16 plus or minus 3. Now, is this significantly different from each other? That you are going to answer that using the student t-test. The output is called the p-value. Right, you've all heard p is 0.05 and less means it's significant. What that means is if you suppose conduct the study 100 times over, you will get the same result 95 times and you will get different results 5 out of the 100 times. If it is 0.98, that means you will, if your p-value is 0.02, it's even smaller, right? You will get the same result 98 out of 100 times. Right? If your p-value is 0.50, you will get 50% of the result the same times. If your p-value is 0.90, that means you will get the same result 10% only, and you will get a different result 90% of the times. Right? So basically what we are trying to say is, how reliable are these results? So if 0.05 nahi hoke, suppose it's 0.07, will it really change humongously? Maybe not, right? So you have to look at that p-value and then decide what you are actually going to do. So we come to this question again. CMT reduced from 480 plus or minus 130 to 320 plus or minus 80 in one group, and the other is now. Second question is this, or first question is this a continuous or a categorical variable? Is what you have to think about. So I'm sure you are all muttering on mute, but then this is a continuous variable, right? This is microns, this is thickness. And this is, this is microns, right? So there is plus or minus. It is normally distributed because the standard deviation is less than half the mean. For 240, 480 is half is 240. This is far less than that. 320, half is 160, right? So standard deviation is far less than half the mean. So this is normally distributed. Right? Let me go back to this chart. So this is a continuous variable. It is normally distributed. What test will you use to get the p-value? Very simple, right? So even here, it's continuous variable. There are 2 groups. It is normally distributed. We use the student t-test, right? Something like that. This is another example of a study from COVID. Here, if you see diabetes in control group versus some patients treated with remdesivir, so diabetes is there in 26% in the control group and in 41% in the remdesivir group. P is 0.001. That means there are significantly more diabetics in the remdesivir group compared to the control group. These are percentages or categorical variables. So what test will you use here? I'm going back. This is categorical variables. There's not much to choose from. It's just chi-square test, right? So this p-value is derived from chi-square test. Now, why this becomes important is suppose you say, oh, the mortality rate in remdesivir is very high, so it's not a good drug. But can you actually say remdesivir is causing mortality, or do you think it is maybe attributable to diabetes? isn't it? So then that diabetes becomes a confounder, right? It becomes something which is interfering with the mortality and the drug, right? So these are confounders, but comparing across diabetes between control and remdesivir group, we have used the chi-square test. There's some other tests, some other examples. We don't have much time to go over these. Last, we'll talk about about causality or regressions. Again, it is based on the outcome measure. If the outcome measure is a continuous variable, we use something called linear regression. Now, continuous variable and linear regression, common example you have is the SRKT formula, where the outcome is a continuous variable, which is IOL power. And it depends upon what two variables we know, right? It depends upon axial length and keratometry, right? So they are examples of linear, IOL power calculations are two types. One is a theoretical formula, others are regression formulas, right? Yeah, so that word regression comes from this. This is linear regression. So if you want to use continuous variables as your outcome measure, use linear regressions. If your outcome measure is a categorical variable, say you want to talk about risk factors for poor visual outcome. So you say worse than 660 and better than 660. Now that becomes a categorical variable, right? Or you say poor response to anti-VEGF, or you can even say good response to anti-VEGF, or you can say, success of a surgery, failure of a surgery, or whatever. So when you have that kind of an outcome and you're looking at risk factors, you use something called logistic regression, and you use outcomes are in terms of odds ratios. And there are several more. We use survival data, and so that is time bound, where I think Apurva showed one example of a survival curve, but there the outcome is also categorical, but it's time dependent. Say mortality in you all talk about 5-year mortality in cancer chemotherapy, or sometimes we talk about dropout rates, or rather failure rates in surgery over time. So when time comes into the picture, we use something called the regression analysis using survival data. So these are different types of regression analysis which you can also do. So for the glaucoma study, dyslipidemia and glaucoma, outcome is glaucoma, isn't it? Some in the dyslipidemia cohort will also get glaucoma. Some in the non-dyslipidemia will also get glaucoma. So how many times more? So you will say, oh, glaucoma is 2 times more common in dyslipidemia versus non-dyslipidemia, right? So, or 3 times more, or 1.5 times more, or you will say 70% more chance, or whatever. So that is, now these are regression analysis using logistic regression. So the way cigarette smoking was determined to be cause of lung cancer is using regression analysis. The biggest advantage here is you can actually neutralize the effect of all the confounders, where you can say, what if all use the same number of cigarettes, or if between diabetes or between dyslipidemia and glaucoma, what if the level of diabetes were the same? What if axial lengths were the same? What if all the other factors were the same? Does dyslipidemia still cause glaucoma? Right. So that's really the question we can answer. These are these are utilizations of regression analysis. So this is again the book. You can download this ebook whenever, and you can go over it, and pretty much everything that you discussed is part of this ebook. And also you can try and take a quiz and really see whether you are actually getting these concepts or not. That brings me to the end of this. So this is my website. You can take a look, and there are courses, and lots and lots of people have actually done these courses and are doing really well and publishing papers. So there are little longer courses, and like I said, you can take a look at the website, and there are a lot of blogs on p-values, on regressions, and on interpreting odds ratios, thesis to journal articles, sample size, and a lot of these, about 32, 33 blogs are there. So feel free to take a look at some of these educational materials and try and broaden your research horizons, not just your surgical horizons or your clinical horizons. That's because a lot of it is going to get outdated. A lot of it is going to not be with you. The way to update, the way to unlearn and relearn is by reading papers, and you will only get better at it if you know some of these concepts that we talked about, right? So it's really about broadening your horizons and going far beyond so many others can. Thank you so much, and if you have questions, I can take them now.
Thank you, Dr. Sen Gupta. It was very informative talk, and I am myself is so scared of this handling data, large data sets. It's very helpful for us, and our DNBs and fellow will definitely take your help for publishing in future. So can we have questions for Dr. Sen Gupta? Please unmute yourself.
This is Dr. Mandeep here. Can I ask a question?
Yes, sir.
Yeah. So actually, just when I heard Dr. Sagarika ma'am's question to the previous talk, and when I'm looking at these two talks, so I went back to my residency days when I was supposed to do the my first project, and it was like how to go about it. So designing the study, and then what about the statistics, and suddenly you face a situation that Excel sheets you are not very conversant with, and then you seek out a statistic. That is a frequent question even now after so many years. Most of the students, they come, okay, can you help me identify some statistician who will help me? So in my personal experience, it was something like two blind men trying to lead each other. The statistician would just sit in front of his software and ask you, what do you want? And then I'm just wondering that this person is not very conversant with the clinical study structures. He or she will help you only when you yourself know the questions that you want answers to. So my take on this is that I think maybe Dr. Sabyasachi can help me with this, that there's a certain number of expertise that can be gained.
Are you still talking, or?
Dr.
I'm not really
Mandeep,
sure.
you're not audible, if you can hear us. I think he lost the connection. So there's one more question, sir. I would encourage my DNB student to ask that question herself. Dr. Tolika, can you please unmute yourself and ask your question?
Good evening, ma'am. Good evening, sir. So my question was, sir, can you please explain the concept of a confidence interval that is often cited in a study, which I've never truly understood.
Yeah,
Thank you, sir.
so take the example of a okay, say efficacy of a vaccine, which all of us were grappling with before. So you say one vaccine causes 90% efficacy and the other is 92% efficacious. But if you were to do that study in, say, 5 different populations, will you get the same number? Some will have 85% efficacy, some will have 87%, and some will have even 93%, right? So it will never be the same number again, isn't it? So, if somebody asks you, what are my chances of success if you do this retinal detachment surgery for me? And you will say, oh, it's 80%. But will it always be 80%? No, it will always generally be a range, isn't it? So that's the best way to understand confidence intervals, where 95% of the times your answer will lie somewhere between this range. Right. So that is what it is. So with vaccines, say it's 90%, but it varies from the 95% confidence interval is 88 to 92%. That is with one vaccine. The other vaccine, you'll say it's also 90%, but it varies from 72 to 98%. Right. So which one will you choose now? You can unmute and perhaps tell me, which one do you want to choose? The one with the smaller or one with the larger confidence interval?
The smaller confidence interval.
Very clearly, right? So, so if you want to say plot these numbers, then you will see that how much overlap is there between the two. So IOP drops by about 5 millimeters of mercury plus or minus say 2.5 millimeters in trabeculectomy group, and the other group, instead of 5, you say now it drops by 6 millimeters of mercury plus or minus 2 millimeters mercury, right? Now, if you want to plot it on a graph, you will see, so you want to know the confidence intervals and then how much overlap is there, right? So if there is a lot of overlap, that means, many of the times it will be the same, right? There will not be much difference between the two. If there is not much overlap, so say one drops IOP by 5 plus or minus 2, the other drops IOP by 5 plus or minus 7. That means there is a lot of variability all over. You will still see that p-value will be statistically significant, though the means are the same or nearly the same, 5.2 and say 5.7 or something. But because that one group has too much variability, standard deviation is large, it will tell you statistically significant, right? So 95% confidence interval, in terms of understanding, I told you how to look at it, and in terms of interpretations, it tells you whether there actually is significant difference between the two groups or not. Many times authors will, with reviews, we understand that somebody is lying about their p-values. They'll say p is less than 0.05. But as soon as you see the actual values, you will realize that, oh, this can't be. That's because, one group has very large standard deviations and the other group also has large standard deviations. And there is likely to be an overlap between the two, and therefore it can't be significantly different from each other. That's how smart reviewers will actually, catch you and tell you, that you're lying many times. So overall, the concept is, if I am looking at anything, what is the chance that my answer will be correct 95% of the times? That's really how you look at confidence intervals. I don't know whether
Okay,
that's,
sir.
yeah.
Yes, sir. Yes, sir. Thank you, sir.
All right.
Thank you.
Thank you, Dr. Sengupta. Now we will be scared with data less, I guess, after your talk, and we'll take the help of your book. Of course, all our students would love to read that book.
It's just
And
5
I
pages.
would just like to add one comment.
5 pages.
Uh,
Very quick.
As Dr. Sabyasachi mentioned, that your spreadsheet or your Excel sheet is very important, because if you put the most important factors, then it's easy for you to analyze. And I think I remember having a discussion one day with Dr. Sabyasachi, and he said that it's good to know your own statistics. And if at all you're on your own statistician after learning all of these things, then it's the best analysis made, because nobody can judge your statistics better than you. Do you agree, Dr. Sabyasachi, sir?
Yeah, so you can also do your own statistics. It's not at all difficult today. So the software which you can use and which is entirely free, and perhaps the best software out there, is called R. The word is R. So you can just download R, but the problem is you have to learn to talk to it. It's like, if you go and talk to a Russian lady, she's not going to understand what you're saying. Even if you want to say that, oh, you're the most beautiful woman in the world that I have ever seen, she'll be oblivious. She'll say, oh, whatever. She'll say something back to you, and then you won't understand what she's saying, right? Even if she's saying that you are the most handsome man in the world, you won't understand. So to talk to the statistical software package, you need to know its language, and that is called syntax. So you need to learn the syntax of whatever software you are using. Our syntax is a little difficult to use. But then there are other software, other courses which will teach you how to use R, including some on their own website. So then if you make an effort, you will be able to use R. So the box and whisker plot which I showed you, which was more conventional, was using Stata. The one which was, which was more colorful, was actually made with R. And so, I use both interchangeably. So you can actually learn to use R. The problem there is you won't know which test to use. Should I use the Shundi test or should I use a chi-square test? And so that ebook that you've gotten will help you. Some of my courses will also help you choose, which test to do. But then you can actually do them using R yourselves. A quick hack is, so before I leave you, quick hack is you can ask ChatGPT for a syntax of R, and it will tell you 910 times. Unfortunately, you will still not be able to use it. You need to do some basic homework about R and how it works. And then, so R, the body which designs R, is working with ChatGPT to simplify. So you just tell it, these are two groups and I want to know the mean difference between IOP. And there you go. It'll just zoom, it'll come out the way you want it, right? So that's all in the works, but it'll still take a bit of time to merge the two. Both are free, right? ChatGPT is free, so is R. So then, they are working on integrating. And lastly, the biggest demand by 2030 is going to be for medical data analysts. I think somebody was asking, right, before he got cut off. Medical data analysts will be the most in demand. If somebody is doing automated cataract surgery or robo is doing surgeries, and you have to keep an eye on 100 robos, you are not going to be able to look at their surgeries. But what you will look at is their spreadsheets. A company will come and tell you, Apple, for example, will come and tell you, oh, this is a spreadsheet of the past 100 surgeries. Please tell me if the robo has made any mistake. And you have like 5 minutes. You'll be like, oops, okay, where are the videos? They'll say, oh, no videos. It's a spreadsheet. Just tell me the answer. And you will be like, if they give that same spreadsheet to the brilliantest of all statisticians, do you think he'll be able to find any answers? No, because he doesn't know the question. How do you frame a question? He has no idea. Will you be able to find the answer? You know the questions, you don't know how to find the answers. So amalgamation of two is a medical analyst, and please try and be one to do whatever you want later on, because otherwise a lot of us might not do what we are doing today. So thank you.
Thank you, Dr. Sengupta. That was pretty impressive. With that, we are moving to our next speaker, and let me. So Dr. Rolika Bansal has done her MBBS from Kasturba Medical College, Manipal, Karnataka, and her MS from Karnataka as well. She was a fellow in ocular oncology and oculoplasty under the mentorship of Dr. Santosh Hunawar from Center for Sight, fellow in ocular oncology at Wills Eye Hospital, Philadelphia. Currently, she's a fellow in ophthalmic plastic and reconstructive surgery at Shirley's Eye Institute, US. UCST. She won impressive 60 awards in ophthalmology, national and international, 90 research projects, including 3 clinical trials, 57 publication and 40 index and 5 book chapter, attended and presented research work at various national and international conferences. Dr. Rolika Bansal has impressive background as far as research and publications are concerned, of course, with highlighted key achievements. May I invite Dr. Rolika Bansal for her talk?
Thank you, Tulika ma'am. Thank you so much for the opportunity, and thank you to Dr. Santosh Unnavir sir also for believing that this topic can be discussed very well. Is my screen visible?
Yes, Dr. Rolika. Please go ahead.
Okay, perfect. So now, after you have learned about how the study design should be and how the statistics have to be carried out, let me just take you briefly through my topic. So when you look at the screen, what do you see? You see that this is absolutely old and gold. And you can see multiple things spread out, very difficult to search for, definitely not organized, but again, old is gold. But now we move on, and in today's scenario, in today's world, it's all about search and organize. Is that right? So when you talk about research, it's important to understand how to do a literature search, and how to organize your literature search. So I'll be talking about the same. So I have no financial interests, and I do not have any preferences, or maybe I do, and that would be a lie. And choose your own poison. I always say that because, again, research is never easy. And it's always going to be something which takes you through the process of procrastination. So I would always call using a research engine or research or reference software as choosing your own poison. You're always welcome to go back to the old and gold style and waste your precious time. But it's good to know what's new and how to go forward. So why do we need literature search? Now you've understood that there is a research question, there are clinical trials and how to do the analysis, but the next and before rather the analysis part would come the literature search. I consider literature search even before your research question is generated as the prior step, because until and unless you've done your literature search, you will not be able to know what kind of question do you want to frame. Once you come up with a question in your mind, it's important for you to sit down and look for what has been done in the past. It's important to understand what is missing, and it's important to understand what you need to add to the literature going forward. A lot of postgraduates and even fellows and even researchers come and question this part, that which topic should I write on? And I think the ethical part, which Dr. Unnavir will be addressing in the end, the ethical part is that you need to understand what you are adding to the existing pool of literature. It's really not about building your CV. Till now, probably the first ever paper that I wrote in MBBS days was to build my CV, and that was the only paper I wrote for that. After that, it's all about getting to know what you need to add to the existing pool. Otherwise, you're just doing what everybody else does and not doing something substantial. So it's important to do literature search. It's important to survey valuable and the most recent information. Then only you can add what is not known. With digitalization, scientific literature has significantly increased. It's not actually simplifying. Like when you go to the olden times of library, you have like n number of books in front of you, and that's okay. But now you have n into 100. It's easier to search literature than the old school library method. So even if your 100x exists, you're still able to recruit it well because you can organize it well. Search engines, meta search engines, and subject directories are what are available. Challenges to filter through the available literature ethically. It's extremely important. I myself find myself lost in the pool of literature when I start doing the literature search. A single search tool leads to loss of 70% of relevant citations, and I'll show you how. Before we go forward, we should know the names of search engines: PubMed, ScienceDirect, Scopus, Google Scholar being the four primary, and there are several other search engines which are available. Talking specifically about PubMed, which is the most highly recommended and highly utilized search engine that has been started by National Library of Medicine in 1997. It's the free software, website available. It uses meshworks and text words and Medline records, and it uses filters. And I'll show you the utilization of filters in some videos that I have. Other search engines would be ScienceDirect by Elsevier. Scopus is an improved version, or rather a different version of ScienceDirect, and again produced by Elsevier. And again, we have Google Scholar, which has a broader perspective, and I'll show you how. So focus on this video. It's a screen shot video that I have taken from the search that I have generated. So when I put up the words like retinoblastoma, intravenous chemotherapy, just these words, when you search on Google in general, you see 730,000 results. Okay, and it took 0.42 seconds to generate that. But when we go forward, I hope my video is moving. Okay, now when we go forward, and you see there are all these results generated. But when I go to Google Scholar, it reduces my spectrum to 18,300. And they're more concise examples I'm getting. When I go to ScienceDirect, it's 2,611 results. And again, it's more confined and more narrowed search that we are getting over here. And on PubMed, we get 226 results. And in 226 results, we have the most relevant, highest cited articles, and you can always sort them by however you would like. In this, I have sorted it by publication date. So you see how 4 different search engines bring you down in different ways. When you narrow down, the different search engines give you different results. So, sorry. Yeah, but when you go now, for example, when you talk about searching, now this is when I've given you an example of searching for one particular article. You have keywords, you have conclusion. From there, you can take your relevant component, and at the bottom of every article, you will see similar articles. So in the similar articles, you can always connect yourself and go to the next search. Now I've clicked on the next one and I've gone to another relevant article in the same thing. This is another disclaimer, a very dangerous thing to do, because I find myself lost in this entire pool and I feel like, okay, where did I even start? This is when your ADHD kicks in and you go like, oh my God, like, where did I start? I thought I started on the intravenous chemotherapy, but now I am on RB1 mutation analysis. What's going on? You need to stay confined to your literature search. You cannot jump across to different topics. So when we talk about Boolean operators, you must have heard about all of them. It would be and, or not, and I'll show you how it changes. And would be retrieving results that include all the research items. That means like, 2 topics if you're choosing, it's this and this put together, which will be which article. Or will be like either this or that, and are these 2 words included in the research separately or not? Not is when it excludes the retrieval of terms from your research. Now, when I give you an example over here, this is how we started. We started with retinoblastoma intravenous chemotherapy. Now I go back. This is the part when I've included and. When you include and, you have 226 results, but when you have or, you have 2,89,049 results. So you have to choose how to narrow it down further. And then you have this entire spectrum. Also, PubMed gives you additional filters, like you can filter by species, language, sex, journal, or even age. These filter tabs depend a lot on what topic that you have in front of you. And okay, so now going forward, we also have a separate segment in PubMed which talks about only the COVID articles, and you can see those data sets being there. Most of the COVID articles are available for free. That's something that was an obligation made. And you have data tools and publications like LitCovid, which gives you a literature search for COVID specifically and separately. It's always good to explore these if you're writing an article on COVID, because even now I get a lot of reviews. People are still writing a lot about COVID-19, which is good because we are having long-term side effects as well. So good to know that. And the most important part going forward is how to organize yourself in this whirlpool of literature. And that would be, why do you need to organize your research? And rather, I would say, why do you need a reference management software? I personally consider it a very important part of even framing a question, even framing a research question. When you start thinking, you should be able to pen it down. So need for reference management software is, for example, if you have to go for grocery shopping, what do? Sometimes you can just go there and you can look for what is available, but you need to put things in your cart, right? So this is exactly the same system. When you go and do your research about literature, you should be able to put certain segments in your cart. And time is precious. Organized ethical research is important and mandatory. I've used the word ethical 3 times till now. The reason is I really want to emphasize it time and again that your ethics matter a lot when you do research. You're not doing research for the purpose of CV. You're not doing research for the purpose of climbing up on the ladder of becoming a professor. Categorize your citations. It's extremely important. And you should back up your references, and I'll show you how. It has a long-term benefit when you are able to manage your references, and it is less cumbersome once understood. Several reference management softwares are available, and I will be talking about them. EndNote is one of them, which is one of the paid softwares with a wider access. And I'll show you how, I wish I could show you the difference between between the paid and unpaid ones, but I have heard several of the paid users say that EndNote gives you a wider spectrum and more facilities to be able to store your research. And ReferenceWorks is one of the softwares generated at ProQuest. Mendeley is a free reference management software. My colleagues also prefer Mendeley. I personally prefer Zotero, which is something by choice or rather by habit. Like I started first with Zotero and I'll end up using it. And therefore, I've been able to, I can only introduce you to what I'm comfortable with or what I've been using or the poison that I chose. So when you talk about Zotero, how to start? Let's just take it like slow and make sure that we all are aware of one software at least, and you can always go and explore the others. Or if you're exploring other softwares, trust me, no software is better than the other. It's all about what is your comfort. Many softwares are available. It's important for you to understand what you would like. So when you start about Zotero, just simply have to go to the Zotero website and click on download. And before, it's a very easy thing. You just land up downloading your software. But remember, always download this most important part, and that is the Zotero connector. And it is available for all sort of browsers. You can choose a browser and download the connector as well. And when you do that, when you restart your computer and you go back to Word document, it appears as a small tiny icon that has been added, and that's called Zotero right there. And also, this is the corner, right upper corner of my screen, and that shows that Zotero remains like this as an icon, which is the extension that I have added. Now, let me explain this to you by example of how it works. When you download Zotero, you have to keep the software open. And when you go like this on this is your page, your browser. And on top, can you see that folder icon? That folder icon is the part which is Zotero. That Z is now the folder icon. So now I'll show you by example. So for example, I open this particular paper. Now this has this entire paper. I read about it. I go like, okay, this is what I need. I need to take the segment, and I just click on the Zotero icon right there. It asks, where do you want to save it? You can choose your folder. These are different folders that I have. This is my library folder of Zotero. I go to the retinoblastoma folder and I hit done. So now this is just saved. Now, every single thing about this particular paper is there in the retinoblastoma folder in my Zotero. Now, I'll show you how that happens. Also, you need to understand when you're reading the paper, you should be able to gather everything that you need from it. When you go to Zotero folder over here, this is how the software looks like. And this is how I like to sort my library, and I like to sort everything by folder mode. You can choose what you would like. It adds everything about the particular paper in your software, from which page number, from DOI, from even your abstract, and everything gets added and sorted over here. Every single folder of mine is disease related, and that's how I like to save it. I sometimes even like to save it by the chapter title that I write, and it's completely dependent on how you like your organization to be. Now, showing by example of how this works. Now, you can see there are two lines written. Line 1 is from one paper, line 2 is from the other paper. I have taken the line as it is to show you, but you should not be able to take a line ever from a paper. That's plagiarism. So when you put this part over here, I'll show you an example. So now when I go to Zotero and I hit add citation, it gives you choices from AMA to Vancouver, even superscript brackets, everything is available. And when I hit on citation, I go like, oh, this has been taken from Lancet, and it gives me the options, and I can simply choose which study, and it goes as superscript. That's it. That's all you have to do. And other option, like I'm adding the other citation where I go like emerging. You can use a word from the paper title, you can use the author's name, you can use the journal's name, whatever, and it searches. And then I write references, and I go again at the bottom, and I just hit add bibliography. The moment I do that, bam, it's all there. Okay, now, for example, I want to switch the line. I want to switch the sequence. I take the second one to top, and I hit refresh, and bam, the reference changes. So it's basically how you can organize everything very quickly. There were times I remember when I was helping one of my seniors from my MS days, is that when he asked me that, can you please change the reference number 126 and make it to 84? And I was like, oh my God, that means that I can make it 84 fine. But then from after that, 85 till 126 has to go to the next number. You don't have to do that anymore. This gives you a quicker system, and I think it's important to save your time. And this is the part which I extremely highly recommend to all the mentors. It's important for you to understand Zotero, because if you share your Word document to your mentor, and your mentor is not using Zotero, so the moment your mentor starts editing in Zotero, it lands up delinking Zotero completely. If they change anything in the document and they are not using Zotero, it delinks your Zotero. So when you get back the paper, you have nothing there. Now all your citations that you had added are delinked. So it's easy. There's something called as export library. So when you're sending a paper to your mentors, if they have understood the concept of Zotero, which is very easy and fast, then you can even send your library as it is to them. They can click on it, and the entire folder will get saved on their Zotero as well. So easy. They don't have to do the entire thing again. You've done it for all. So it goes completely from one computer to the other with all citations done. So to conclude, literature has a broad extent and multilateral addiction. I really call it a multilateral addiction. You can go from one to the other. And researchers must use different search engines. It's extremely important. Each search engine has different abilities and services, and a combination of different search engines is the key. I would say don't restrict yourself to one, because then you have 226 articles, and do not even go to the extent of using a very generalized system where you have lakhs and lakhs of articles to go through. You should be smart, and you will get to know how to do that with time. And choosing the most user-friendly software is a personal preference. There's nothing good, there's nothing bad. EndNote is amazing, Mendeley is amazing, RefWorks is amazing, and so is Zotero. It's about what is your comfort zone. And reference management software save time and make it 100 times easier to arrange the sequence of citations. It's easier and faster. Categorization and backup of citations is highly advisable. So organize your research, organize your mind, organize your life, and also make sure that whatever work you do stays ethical, and make sure that you convert your research into your papers. If you see my CV that there is a gap of 50 papers that I should be still writing. So it's a waste of your time if you do research and you don't publish them. Thank you very much.
Thank you, Dr. Rolika. That's wonderful talk. I myself use EndNote, and it is pretty similar like Zotero. So, but it is paid, of course. I pay a fortune for that. But yeah, it's really wonderful device for me. So yes, and I would encourage all the students or the young researchers who are working with this kind of research should start using the softwares. So any question for Dr. Rolika? So we don't have any question right now. We might have some question by the end of the webinar. So we'll take your questions. Sorry,
sure.
Somebody want? Doctor, okay. So let's go to the next speaker. So Dr. Vanity M, she's MBBS from Madras Medical College, Chennai, postgraduate from AIIMS, currently serving as faculty professor and senior eye surgeon in AIIMS, editor-in-chief in IGO. She's the first woman editor of IGO, nominated as council member of Afro-Asian Council of Ophthalmology, has held several key office bearer position in AIOS, DOS, and the professional societies. Sorry, there's a lot of noise. Sorry, yeah. Expert corneal cataract and refractive surgeon with expertise in medical and surgical cornea, all type of keratoplasties and stem cell transplant procedure. Very popular teacher in RP Center, of course, and the contribution in several international national conferences as per presenter and instructor, more than 250 publication, more than 80 chapters in international ophthalmology, subspecialty books, more than 200 presentation in national and international conferences, and the list goes on and on. And the books she has written, postgraduate ophthalmology and undergraduate ophthalmology. Winners of AIIMS Research Excellent Award, AIOS Achiever Award, several Best of IGO, AIOS, IGO Silver, and Appreciation Awards, AIOS Casey Single Award, TP Agrawal Trophy, DOS, Best Paper Award, etc. There's so many achievements. So Dr. Vanity is highly regarded in the field of ophthalmology with over decades of experience. She will share her experience on how to write a publishable manuscript. Over to you, ma'am. Over to you, ma'am.
Thank you, Tulika. And my screen sharing says the other participant is sharing. Somebody has to.
I have already stopped sharing, ma'am. I was sharing
Nobody's sharing. Yeah, I'm able to share now. Yes. Yeah. Is my screen visible?
Yes, ma'am. It is visible.
My screen is visible. Okay. Yeah. Yeah. At the outset, I wish to thank Dr. Hanavar for having included me in this very lively webinar and with very, very aptly placed talks, which have sort of summarized the crux of what one needs to know when one is dealing about research work and how to go about its publications. I have no financial interest in the mention of anything during the course of this talk, and a very nice way of putting it by Dr. Hanavar is the proof of the pudding is in the eating. So if it has been cooked well, you would relish it when you would eat it as well. And that's the analog here. And how would you really write a publishable manuscript? It's very easily said, but believe me, I think it takes several years of experience before you would really master the skill of being an expert writer. And I still feel after having written many manuscripts, I'm still learning to write. And the proof of that was I thought I wrote a wonderful manuscript, and I did send it across to one of our subspecialty top journals. And when it came back, and I think the experience as editor of Indian Journal of Ophthalmology has really taught me not to get upset or not to get angry by the reviewers' comments, but I learned so much from their comments that it helped me to enhance my paper and lift the standards of my paper to a different level. So I think research writing is a constant evolving process. And the more you write, the more your work gets critically reviewed, the better author you actually become or evolve into over a period of time. That's how this works here. It's a continuous learning which you have. But to make it easy for all of those who are just beginning their journey of research writing, I'll just take you through a few tips or pearls which will really help you when you're starting your paper writing, and to make it very easy and make it very concise, and this would let you know what you need to look at when you're writing a paper. So the first pearl is, what are the questions you need to ask yourself before preparing your manuscript? So now we are at the stage, I think we've looked at a lot of the prior stages, and your manuscript, your research is ready, your data is ready, your analysis is ready. So you're going to sit down to write your paper now. And so you would ask yourself, okay, why do I want to publish this work here? So that's going to be the top question, which is going to be there on one. So what is the answer going to be to this question, which you're going to ask yourself here? Is it novelty? Are you having something new which the other researchers have not yet described? Is your work describing something which the others will learn from and they have not read about it or seen it in other studies? So novelty is one thing. Revolutionary. What was challenging in your work? What did you do which was, more convincing that your research data is able to show as a proof of concept compared to the other proofs of concept which are available in this particular field? So was your work revolutionary? 3, influence. Will your results influence the other researchers? Meaning, how is your result or how is your study going to impact other researchers in the field or in the focus group in the focus study subject which you have chosen to publish upon? And 4 is solution. Have you been able to produce or provide a solution to some difficult problems or difficult areas in the subspecialty or the focus area which you're going to be writing about? So this, if your study is going to answer or has one of these as the answer to your question of why do I want to publish my work, then you're probably in the right path here. Then you would know that your manuscript what you're going to write is probably going to see good light here, and you're justified in wanting to publish your work here. So novelty, revolutionary, influential, and providing a solution. So this is what probably or why you want to show your work or publish your work to others. So then we move on to question number 2. Is your manuscript more effective than others? Every time you might not have something new to write about, but then there might be something which is there in your work, which is adding on to the data, which is already out there in the field here. But then why should your manuscript be considered over another submitter's manuscript? So when you are in the business of publishing, you might probably have more than a single author writing about the same subject. Many minds think alike here. So there might be a new concept, there might be a new surgical technique, There might be a new drug which is being evaluated by several people across the world here. So they might all land up, and if your journal is an impactful journal, if your journal is publishing fast, they might want to send their data to your journal. So the editor might be looking at data which is coming to him or her from over than 4 or 5 authors. So what will help your manuscript to score over the other manuscripts when they're talking about similar research? So that's what is going to make an impact about how you write a publishable paper. The clarity of scientific message which you are giving. You must be able to clearly draft the message which you want to pass on to your audience, to the readers of the journal, the target audience here. The author's thoughts should be drafted in a very logical manner so that it takes you on, or takes the readers on to the conclusion, and all the way you write should be such that the results are supporting the conclusion which is derived here. And it should be so logically presented that the reader is in agreement with what you are stating here. If there are conflicting statements, the reader is able to pick that up, then your reviewers are probably going to be more critical and are going to stamp or grade your article as one with low priority for publication. And that's not something which the editor is going to like, or that's going to largely influence the editor's decision on choosing one manuscript over the other. So that's important in the way you're writing. Point number 2, the format of how you're writing here. So the way you write should be able to showcase your research material in the best possible manner. So it's the packaging which is going to be very important. So the format of writing is very important here. It doesn't mean that you need to have a flamboyant control or flamboyant flow of the English language here. It just means that you have to give it in simple English, which is comprehensible to all the readers across your target audience, which appeals to them, and which is reeking of good clarity here. So your writing style is what is most important in your format. Sadly, I think today most of us have stopped reading books here, reading the newspaper, listening to the news in our days, which used to be so rich in the English language. So we all probably also use spoken English and written English in written material, and that is probably not going to be cutting in your favor, or not going to be working in your favor here. So when you do see a manuscript with a lot of typo errors, people do not know where they need to place their spacing, do not know where to place their commas, do not know how their grammar has to be placed, then that is probably going to sort of dampen the spirit of an otherwise well-written, well-done research here. So the format of writing is something which you need to master. And by format would also apply to, for example, you're writing a photo essay, for example, you're writing a case report. Please understand the formats required for these differ from each other. The format of how you would probably write an original article is different from the format of a review article. So these need to be understood. So it's best that you start by reading the submission guidelines, and so that you stick to the format here, and so that you do not have to waste a lot of time in seeing your article coming back and forth from the technical check podium saying this is not in the right format and this needs this correction and this needs, which is largely not a scientific correction, but largely technical corrections. The next is the title and abstract. These are two very important aspects of your paper here. Why? Because the title is going to tell you all about what research you're writing or what research you're presenting in a very concise manner. So the title should not be needlessly long, it should be concise, it should not be obscure. And it's a good practice to avoid abbreviations in your title. Keep your title to the point here and describe the key content of your paper in your title here. So that's something which is a catchy title, or a title which will really win over the readers and the reviewers. And it's how you're starting your paper, and it's how they're going to look at it. Please remember, when people are doing a search, The only two things they're going to be looking at is the title and the abstract here. So these two need to be really catchy and effective so that it catches the eyes, catches the attention of those who want to quote your paper as well. And this will also keep your research as one of the top quoted researchers in the particular field you're working on. The abstract also needs to be clear, it needs to be written interestingly, needs to be easily comprehensible, and it should be accurate and state your research specifically and to the point here. So these are, several adjectives. If you learn to incorporate the meaning of these adjectives into the way you're writing, then your job is well done here. Something to remember that you should not be doing is that please do not use titles because they are fancy. Please remember, in research writing, it's a little different from conference topics. Conference topics, talk topics can have fancy titles here, but not so when you're writing a research paper. The title should not be too fancy, because if somebody is searching for it, a fancy title probably is not picked up by the keywords here, and your research is liable to be missed out by those who are looking at related research in that field here. Again, the abstract needs to be pinpoint and specific, and these should not be misleading or misrepresenting. Several times when we are reviewing a paper, you would find the title is stating something, but when you read the abstract in detail, the way the research is done, or the data which is presented, or its interpretations and the title do not seem to be coherently linked. And this is something which is really not going to go down with the reviewers and your journal editorial board here. The next is something which I always like is your research writing is a story narrative here. So you've done your research, and now we are going to sit down and think, what's the best way I'm going to get the story across to the audience here. So good research writing is like a good story being told in a very interesting manner, which captivates the attention of the target audience. So your writing narrative should be simple. It should be concise, starting with a logical layout of the objective. What does that mean? It sounds sophisticated, but it's as simple as your research question. Have you defined your research question, and have you worded it out in a manner which is captivating and which helps people to sit up and look at your paper? So your research question needs to be something which is not mundane, but it's probably talking about a problem which is current, which is faced by many others, and that's what has become the core of your research here. Then the arguments in favor of why you chose this research question. So that would pertain to the justification for your doing your research, the rationale for the research you have chosen to do here. From here, your story will move on to say, how did I prove that I was able to find out the objective which I started on when I began my research here? So what are the methods I adopted? So that would mean the study design. Is the study design which you chose appropriate and the most apt to reach the conclusion for this particular objective here? So you write about your study design. You write about the methodology, meaning what are all the study parameters you also adopted in order to achieve what you started to find out about. So that's the next part of your storytelling, which will automatically lead you on to the outcome. So by outcome, you mean what were the results I got when I adopted this research using all these study parameter evaluations placed in this study design. So what were my results? And please remember, in the research section, you are simply stating the exact data which you have got for all the parameters you committed that you will be doing for this particular research here. So once that is done, that results is just simple statement, statistical representation of the data of all the study parameters you have committed to do. I'm repeating this again. Observation is the derivation of the inference of these results when you sit and analyze these results using statistical tests here. And once you have achieved this, So you learn to interpret the outcome based on the statistical significance that your data or the numbers in your study has provided here. So that's what you learn by doing your statistical analysis here. And this you need to learn to effectively translate into research writing. Once this is done, you will look at other statements which support the results of your work, meaning your discussion. You would come to the inferences which you got from your study. How do these inferences compare with similar studies which are related to your work? Are they concurring or are they in contrast? You summarize your results and then you end with a conclusion statement here. So if you simply follow this outline as a beginner, you would be going in the right path and you would be able to write a good research paper. The next question which you have to ask yourself is your cover letter. Several times the cover letter is the last one and you probably you start writing it only when you're halfway through your submission. So I've seen several letters being submitted to the editor with the name of a different editor, with the name of a different journal. And these are errors which are best avoided here. So don't underestimate your cover letter. Your cover letter could be a very impactful tool which helps you to communicate with the editor in whose journal you are submitting your paper here. So you would probably state or write to the editor saying why you think your paper is good for his or her journal here. You will include the background information which is related to your research, but this information is probably not included or is not featuring in your abstract here. So that's something which you can state and tell the editor that this is what is there in my research here, which helps to draw the attention of the editor to the particular research which you're submitting to the journal here. And write in brief about the research question and what's the importance of its impact in the focus area you're been working on here. If there's a particular controversy which you need to address or you have effectively addressed in your research writing, that can also be included, and this really helps when the reviewers and the editorial board is looking at it. And the last is avoid inclusion of the abstract, your accomplishments, the details it's really not going to be working in your favor here. Again, please, this is something which I already told you, that talk about the impactful results in the results section here. And your results should be presented in a very easy, comprehensible manner here. And it should be, if it features novel findings, it scores more for you. Provide a very good analysis and how detail it well enough when you're writing about it here. You could use paragraph headings to describe the concrete finding. And sometimes I do find figure legends are not written very nicely. It's a good habit to also give headings, subheadings for your figure legends here. So it allows the reviewer to easily locate a related graphical representation of your data as well. Then the results and discussion sections should be sort of well integrated. They should not be like they're two different paragraphs, different from each other, but they should be integrated with each other. And that helps or scores more with the reviewers and the editorial board. Another important part of your paper is paying attention to the references. So we heard a lot about how you need to place your citations, how you need to choose the softwares which you're placing for your references here. But along with that, what's important is also that please cite the main scientific publications on which your work is based. Please remember, you comprehensively include the top scientific citations which are there related to the work you are presenting. Again, it is not a good idea to use too many references. Limit your number of references here. Again, understand how to use your you use your citations to your best advantages. Several times citations are placed in are quoted incorrectly, so that's something which really puts off, and it sort of tells the reviewer that this paper has been written very frivolously, or very poor attention has been paid to the most important part of the paper writing. So that needs to be avoided, and then it would work in the favor of a rejection if you find that the citations are being inaccurately quoted here. Self-citations is another aspect which is best avoided here, and try to keep it as minimal as possible, even if you have to cite work done by yourself in the particular field here. Avoid excessive citations from the same geographical region here. And always it's a good idea to acknowledge all those who have been productively contributed to your work as advisors, those funding agencies, related personnel like your statisticians or anybody else who really helped you with your research. And that's a very good idea to acknowledge all of them. Again, a bad paper is something which is encouraging ghost authorships here. And that's or guest, I'm sorry, I should say guest authorships. And that's again a very bad idea, and doesn't speak well of the people who are offering guest authorships to others, which also points towards, which also places questions on the credibility of the research which is being done. So these are all very important aspects, and I will just quickly run you through a particular study. So just to tell you how you could probably, as an example here, we'll come back to the abstract later. So this is one paper which talks about a comparative evaluation of an intraoperative aberrometry with a Barrett-Storick calculator. So it's a good idea to see how the research, how the introduction should go about here. So this work is basically talking about refining refractive outcomes. So that's how the paper starts. So, and that's the beginning of the story which is being told here of how you would go about refining refractive outcomes in cataract surgery. And what is these particular formulas looking at? They are looking at refining corneal astigmatism, or they are dealing with corneal astigmatism in cataract surgery. So that's how your introduction is leading from one aspect of the story to the other aspect. But why did you look at only these two formulas over a wide variety of formulas? Because they pay particular attention to the concept of posterior corneal astigmatism, and they are probably helping you to refine your outcomes better than the available softwares which were there at that particular point of time which this study was done here. So what should be the length of your introduction? What should your introduction be? Talk about or lead questions on people who start looking or start writing a paper here. So that's how this particular paper has started writing it out. And you would also see why you chose these two formulas, and you justify why you chose this, and what were the subjects chosen for this, and what was the purpose of this particular research. The methodology starts with stating the what is your study design here, which is an interventional, which is an observational study. Several times when these are done as thesis, they are placed as observational studies, because once you write it's an interventional study, then the interventions also need to be funded by the agency which is doing the research, which becomes difficult for medical colleges to fund different intraocular lenses, because that's the intervention which is being done. So it's purposefully put as an observational study, which means you're looking at you're observing the data of patients who have undergone cataract surgery using this modality of surgical technique or that particular formula. So these are ways by which you could probably work around your methodology to suit it best for the nature of study. So if you're having a funded research, you have a larger time period, and you have enough funds available, then an interventional study, it's again the same research, but the way you put it across, depending upon the participants in the research and the purpose for which it is done, you would still be able to very effectively and cleverly take your research across to the target audience in the best possible manner here. I think statistics is something which again was beautifully outlined by Dr. Sen Gupta here. Look at all the relevant display of statistics for your paper. A good statistical explanation, a good statistical graphical representation, appropriately not duplicating text is something what the reviewers and the editorial board is going to be looking at. And there are several ways of depicting your data, and best is to work in close tandem with your biostatistician to look at what tests would probably be more apt to state the results here, and a good graphical representation in a correct manner, and optimally use statistics without any plagiarism or without any falsification. Please remember, most reviewers who are masters in their field of review will be able to pick out, as Dr. Sengupta rightly said, whether you are stating a fact which is true or which is not true here. So that's an important aspect which you will also have to pay particular attention to. I think I'll stop here because I've already exceeded my time, I think, and I wish to thank Dr. Santosh Hunawat and the organizing team at CFS for including me in this wonderful lecture, in this wonderful webinar. Thank you so much.
Thank you, ma'am. The talk was truly outstanding, and it is very helpful for all of us who are writing publications. And the
Thank you,
students
Dr.
are
Tulika.
definitely
Thank you,
very
Dr.
helpful for us.
Mhm.
Do we have any questions for Dr. Vanati? We can have questions by the end of the
Maybe
webinar
at the
as
end,
well.
yes. Yes.
Yeah, so with this, we'll go to our next speaker. So Dr. Santosh Hunawat, he is MBBS from Bangalore Medical College, MD Ophthalmology from RP Center AIMS, trained in ocular oncology under mentorship of Professor Jerry A. Shields and Professor Carol A. Shields, Wills Eye Institute, Philadelphia. Head Department of Ophthalmic Plastic Surgery and Ocular Oncology and National Retinoblastoma Foundation at Center for Sight. Established the Ocular Oncology Service, the first such facility in the country, and was former Associate Director of LBPI. Adjunct Professor at University of Rochester and Case Western University, Cleveland. Council Member of APAO and Scientific Secretary of ISO. Past President of Asia Pacific Society of Ocular Oncology and Pathology. Member of Oculoplastic Committee, AO, and Advisory Board of ICO. And the list is long. Dr. Santosh Hunawat needs no introduction. We are honored to have you, sir, with us to share your knowledge and perspective. Over to you, sir.
Thank you so much. Right. I'll be talking about publication ethics. I think publication ethics is not just a transient line on sand. It is supposed to be an indelible Lakshman Rekha, and you may not end up with just a free trip to Sri Lanka, but here the consequences can be very severe if you transgress this particular line. Everybody has a role in ethics: authors, reviewers, publishers, and editors. And here I'm going to specifically speak about the role of authors in terms of ethics. It's not necessary to say that research is based on trust. Unless it is based on trust, there is no value to research. If somebody cannot use the fruits of your research for treating patients, especially in medical research, then your research is of no use. And if they cannot use it because of lack of trust, then your research is fruitless. Loss of trust has a cascading effect. That means that if you have committed some kind of unethical behavior or indulge in some kind of unethical behavior in any of your publications, all your past publications will come under bad light. And even your future publications, and not just yours, but anybody who may be associated with your publications, even the co-authors. So it has a real broad effect, any error in terms of ethics. Trust is difficult to earn back once it is lost, and results of your unethical research can harm lives, specifically in ophthalmology, eyes, vision, and even quality of life, because people may be using the outcome of your research to treat their patients. And some of these treatments may be suboptimal. Being an author involves taking responsibility for the originality of publication, that there is no data fabrication by any of the authors that are involved in the publication, or data misinterpretation. Data and image manipulation. Image manipulation can be very subtle, but that is a possibility. Plagiarism, of course, and appropriate authorship. Starting with the ethics committee approval, it is mandatory for all scientific publications currently. You can have your institutional ethics committee like we have at Center for Sight, or if your institute does not have an ethics committee, or if you're in a different part of the country than the location of the ethics committee, then you can use an independent ethics committee in your own geographic location. For example, if I'm in Hyderabad, and even if Center for Sight has an ethics committee in Delhi, I cannot use it because of geographic restriction. I can use a co-author from Delhi as long as he or she has some authorship responsibility, or else I have to depend on an independent ethics committee. It must be an accredited ethics committee. In fact, now there is a list of accredited ethics committees published by Central Drug Standard Control Organization. And unless it's an accredited ethics committee, it's of no value. So you have to make sure that when you apply for ethics approval from an independent EC, it is accredited. Now, for prospective clinical trials, even theses, if it's a prospective clinical trial, it must be registered. This is a mandatory rule which started in June 2009. The definition is that any trial involving human participants of any intervention, drugs, surgery, preventive measures, lifestyle modifications, use of devices, educational or behavioral treatment, rehabilitation strategies, all come under the purview of clinical trials, and including a PG or a fellow thesis, these must be registered. Unless these are registered, some of the journals may not publish this. Informed consent is mandatory for all study participants. There is an ICMR template. If your institution does not have it, you can use the standard ICMR template. And it should be available even for retrospective studies and for reproduction of images. Even if you submit an image with part of a phase visible to journals like PGO, any journal that has its origin in the Europe, then you should have a written consent from the patient. Sometimes it may be very difficult to get a consent retrospectively. The patient may not be under your follow-up anymore. So my specific advice is to obtain a blanket consent for use of all clinical images from all patients at the point of exit. So whenever a patient checks in, or whenever you do a particular intervention or a procedure, irrespective of whether you're thinking of publishing it at all or not, it is a good idea to have a blanket consent, specifically mentioning that the images and the data may be used for publication. So that will actually cover you for the future. Now, data ethics have several connotations, one of which is fabrication. The definition of fabrication is to draw a conclusion from the data that is not generated from the study. That means that you're falsifying data. Ballooning is fabricating data higher in numbers than the real, like having a multiplication factor. Like if you have 10 patients, if you say 100 patients, then your mean, standard deviation, everything may remain almost the same, but then you are bloating up your numbers just for an intent to get it published. Falsification is manipulating research materials or processes, or changing or omitting data or results that the research is not accurately represented. Now, if any of the journals or the editorial committee suspect that your data may be inappropriate, it is fabricated, falsified, or ballooned, then they may ask for raw data. Well, people have a possible solution here. They may fabricate data and submit an Excel sheet. But then the journals may not stop here. They may even ask for copies of the medical records and the medical record numbers. And you can't go to that extent of falsification, because when they ask for medical records and medical record numbers and copies of medical records, then the head of the institute may have to actually certify that these are from real patient origin. So there is a possibility of getting caught when you fabricate, balloon, or falsify data, and it is not a good idea at all. Plagiarism is the most common way of dealing with things that are not original, in the sense that people tend to use previously published material, which could be language, which could be data, which could be picture, without consent, credit, or acknowledgement, and they pass it off as it is your own. Basically, people use anything, including phrases, sentences, paragraphs, full articles, graphs, pictures, anything for that matter. It's the most common form of publication misconduct. It's like stealing from another person. There are various types of plagiarism. Complete plagiarism is you completely use somebody's complete work, in the sense that the entire article is used, which is previously published, as your own, without any change, any much change. Direct plagiarism is using parts of the article which is published as your own. Paraphrasing is that you have very casually paraphrased what is published, but it is somebody else's work that you have used without much of change. Mosaic, patchwork, or potluck plagiarism is when you very innovatively or intelligently weave in somebody else's work within your own, parts of it, without much change, of course. Self-plagiarism is sometimes inevitable. If you're writing a review article on a topic or on an area of your keen focus. So, for example, if I'm writing some research article on retinoblastoma, I would actually call in my own material that I have published earlier. That cannot be termed as self-plagiarism, but if you substantially reproduce what you have already published in another journal or another quotable source, then that is self-plagiarism. So using your own work without citation can be a plagiarism, but if you use your own work to write a review article with due citations, it cannot be considered self-plagiarism. Source misrepresentation is when you quote or cite a secondary citation, but you might be actually using the primary citation. So basically you're misrepresenting the source from which it is taken. Accidental plagiarism is the most common plagiarism because it happens without us knowing. Sometimes you use phrases, sentences, and definitions without citing them from the original source. So that is accidental plagiarism, and that should be avoided. That should be picked up at the level of proofs, at least at the level of editorial check finally, when before the manuscripts get accepted or published. But it is the most common plagiarism, and it should not happen. And the original authors may actually point out that, well, it is my definition that you're using, or my classification that you're using, without quoting me or citing me, and that should be ideally avoided. How to avoid this? Try to be original. Summarize all available knowledge in your own words. That means that you are actually reconstructing sentences with your own language, but with the knowledge, of course, knowledge pre-exists, but you're rephrasing, reconstructing sentences on your own. And you paraphrase line by line. If it is directly reproduced, sometimes you have to directly reproduce a particular aspect. It could be definition, classification, diagnostic criteria, therapeutic criteria, etc., indications for particular treatment. Then it should be quoted. It should be either in quotation marks if you have completely reproduced a sentence or a part of a paragraph. Otherwise, it should be cited. Always use appropriate reference, and use a software to check this if you have any suspicion that any of your co-authors or the primary author may have used it accidentally. Now, these are the software that are available, some of which are by payment. They charge perhaps $1 for checking. That means about 80 rupees for an article. Authenticate, Grammarly are by charge. You have Paperator, DupliChecker, even Word and Google can be configured to check this, but they're not so robust. But I would suggest any of the top 4, Authenticate, Grammarly, Paperator, and DupliChecker, to be used to check. Now, duplicate publication. Some have a habit of submitting articles to 2 different journals because processing takes time. It may take up to 6 or 9 months for some journals to even take a decision. So without waiting for that particular journal to complete the kind of pipeline of editorial decision, you submit to another journal, and that is considered unethical. You can submit only after a categorical rejection. Even if it is under major revision, you should not submit it to another journal. Duplicate publication of substantially similar material, even in a journal not indexed, is not acceptable. That means if you have submitted or your article is published in a journal like Delhi Journal of Ophthalmology, which is not indexed, and the exact similar material or the same material you submit to an indexed journal, and that is not acceptable because every journal currently is internet searchable and it is considered published even if it is published in a non-indexed journal. But the grace here is that conference publication presentation and publication of an abstract, such as an ARVO abstract. Whatever that you present in ARVO gets published in IOVS as an abstract. If you publish a full article based on that, it is perfectly acceptable. There is no restriction. These are the terms that are known: salami slicing and beef up. Means if you have done a large study with a lot of data, dividing the results of the study into 2 or more publications is called salami slicing. This may be acceptable if each of those publications concentrates on a totally different aspect which is not related to the earlier publication except by the disease. Beefing up is combining 2 data sets to enhance the chance of acceptance. That means that your intent was not to use such a large data set, but finally, after having completed one study, you realize that, well, data is not enough for publication. Then you combine 2 data sets to enhance the chance of acceptance is beef up. Beef up sometimes is acceptable if you have gone back and collected more data. After having collected 100 patients, you realize, well, it's not enough. You go back and collect 200 more patients, that is fine. But other forms of beefing up is not acceptable. The various authorship unethical behavior is that any person who is not a designated or not qualifies to be an author should be avoided. These are the authorship criteria for most of the journals. Author must have made substantial contribution to the conduct of the study, including its conception and design, data acquisition, statistical analysis, and interpretation, or must have contributed in drafting or revising the article for intellectual content, approval of the final version, and the extent of contributions decides the order of authorship. This is legitimate. Then there are 3 forms of unethical authorship. One is a ghost author, that somebody else will write an article for you, but you haven't mentioned that particular author at all because possibly you have got it written up by payment. Gift authorship is you're gifting an authorship to somebody who is a junior. Maybe you want her or his CV to improve. You have some kind of payback because of the hard work that that person has done, or you're gifting an authorship to a senior or a head of an institute, that is gift authorship. Guest authorship is you are using the name of a very prominent person in that field who is an authority on that field just to enhance the possibility of acceptance. All 3 are unethical. Now, conflict of interest is having conflict of interest which is not declared. Having a conflict of interest is acceptable. Many of the current clinicians are consultants in some company or the other with or without monetary gain. That is okay, but if you don't kind of disclose it, that becomes unethical. There could be direct financial or indirect financial conflict. Direct is, of course, when you are paid for it. Indirect is authors receives honoraria and research grants to do the study, paid lectures to popularize the product, yet he does not or she does not disclose it. Self-citations. This is quite epidemic currently. Authors cite themselves to increase their H-index. It is unreasonable to cite yourself more than what is acceptable. Anything more than 5%, 1 in 20 in a manuscript is considered abnormal. There is no prescribed level as such, but 1 in 20 is considered abnormal. 5 in 20 definitely is pathological. You may be having kind of a leeway somewhat if you're publishing a review article where you have to depend on many of your own publications. Review articles allow more self-citations than original articles or case reports. So we have to be careful with it. There are some questionable research practices. One is selective reporting of variables. Collecting more data after the study is conducted to try and make the findings significant. This may be acceptable, may not be acceptable. Reporting selective studies that have worked and not reporting studies that have not worked. Rounding p-value to make it significant, and reporting unexpected findings as having been predicted. AI generated content. Well, of course, this may be a problem in the future when you use AI to generate most of the content for a research paper. This raises ethical concerns due to potential issues with authorship and intellectual integrity. Now, these are some of the software that are out there. You can actually access the software very readily, and you can have these write papers for you. But authors have these tools. These are called AI detection tools. Turnitin, Copylink, Spillbot are the ones which the editors can use to detect if you have used AI to write your article. There's a war between AI detectors and humanizers. Humanizers are the ones which authors use after having got their article written by an AI tool. They can use write human or bypass AI as humanizers. That will AI written article to a certain extent and make it as if it is written by humans, but then editors can always catch it. There is something called paper mill. Mills are organizations that write articles and sell authorship. That means that you have a ready-made article which conforms to your area of interest. They simply sell it to you for a fee. Some of these may be legitimate work. Some of these may be actually heavily plagiarized or maybe fraudulent data, and this is absolutely not acceptable. What are the consequences of unethical publication conduct? Journals or editors, when they discover it, they inform the authors of the misconduct. And if the authors accept the misconduct, reject the manuscript, and inform the institution and the ethics committee which had approved the manuscript, approved the research work. If the manuscript is already published, then the editors generally tend to publish an erratum if the error is minor. If the error is major, they revoke the manuscript, inform COPE member journals, blacklist the author, and inform the institution and the ethics committee. The level of punishment depends on the significance or the magnitude of the ethics demeanor. But then each journal has their own policy and they will take a decision based on that. Well, if the institution is informed of ethical misconduct of a particular author who belongs to the institute, then institute can demote that person, take punitive measures, including termination. This has happened and that will continue to happen. What I spoke already, it has already been, we have published it, Sunny and I have published it in IGO. This is the article and this is the table. Which is a ready reckoner actually. It's a checklist of publication ethics. And this is the article that I'm talking about. It's published in IGO in 2017. You can look it up. Everything else that I spoke is there except for AI misconduct, which was not there so much in 2017. So thank you so much.
Thank you, sir, for sharing your expertise and delivering such a compelling and thought-provoking session. So, do we have any questions?
Ma'am, I would like to ask Dr. Hunavar, sir. Sir, you mentioned about the artificial intelligence being used nowadays to write articles and in research work. But then there are some subset of people who are not very good with their vocabulary. Is there any way to guide them to take the use of artificial intelligence, but to limit it to a certain extent and not entirely plagiarize their publication?
Well, using AI to any extent to write an article is currently considered unethical. But then, well, you can use Grammarly. Grammarly is also substantially AI based, which is subscription based, but it will correct your grammar and language. It will not correct or rewrite the manuscript for you. It will suggest sentences. Paid version of Grammarly can actually reconstruct sentences and make it more grammatically conducive and accurate. But at the same time, it does not substantially rewrite your article. Grammarly is perfectly acceptable, or taking the help of a language editor is also perfectly acceptable.
So,
And
I
sir,
have
also, is there, sorry, ma'am, you may continue.
No, please go ahead, Kanika. Go ahead. Yeah.
Also, sir, we do receive a lot of our students and DNB candidates who keep writing articles and send us for checking. Is there any way to find out if they have actually utilized the AI-based softwares to write their papers or something?
Right. You have AI checkers online, which are free to use. you can they have a word limit actually. If you use a subscribed version, that means you pay per month, or institution subscribes one of those software. All of the faculty from the institute can use the same software. But then the free version has a limit of 1,000 words or 1,500 words, depending on the software that you're using. So you can split that particular article into 1,000-word capsules and then upload these, and readily it will check and tell you that this is the percentage of AI content. So that's easily available online, free of charge, for a limited number of words. And for subscription, any number of words.
So my
Thank
question
you,
is
sir.
for the panel. So most of the article I get for reviewing, they're from the different part of the country, and most of the journals which are reputable, they are written in English. Sometimes the studies are very good. They want to convey the right thing, but the language and the grammar and a lot of things, and they are not aware of using all these things. So these platforms are not available. Nobody's to educate them, what to do. And the only language they can write is in English. So sometimes the articles are rejected on the basis of the language and the syntax mistakes. So what do you suggest?
That I think she has taken some initiatives to get the articles rewritten if the quality is good. I mean, data is good.
So can I? Yeah.
Yeah.
I think if you, as a reviewer, you could always pass on the message to the editor or the board of editors who are looking at your article, that the concept and the message which is primarily being driven in the manuscript you're reviewing is worth publishing, but the authors do need a lot of hand-holding in the language. And then we do have the mentored category, where we put one of the editorial board members or anybody who's willing to walk and teach the person into writing. For that, we would really want the concept to be novel, or the idea and the message which is being given by the manuscript, and the reviewers would, I would really welcome them to give these suggestions here, and we can take it forward to help them out. The other option is there are paid, English language services here, and those can also be, availed by the authors if you probably recommend that to them, and that would also help them to enhance their writing styles.
Can I ask? Yeah. Can I add something?
Yeah, please.
Yeah.
So one thing is that regarding this ethics committee registration, it is in addition to the CDSCO, it has to be from Department of Health Research also, the DHR. There are 2 registrations required now, because actually the academics and all these studies are being monitored by DHR.
Mm-hmm.
And then regarding the blanket consent, sometimes we do get stuck if regarding if you have a specific study in mind, then maybe it is better to take a proper consent for that study.
Correct.
So that when you are taking it as a blanket for any future use, yes, you may be taking a consent for using an OCT or a photograph or something for any PPT presentation or a publication, but if there is a specific study going on, and then it is better to take a consent that way. However, there are circumstances where a waiver of consent is also applicable, because in the retrospective studies, so in certain conditions, like waiver of consent is applicable, specifically if you can demonstrate that there is zero risk involved to the study participant. It is mostly so because when you are only checking the old medical records, there is no patient intervention involved. So that can be easily demonstrated. Next is, like Dr. Vanati mentioned about and you also mentioned about the guest authors. So sometimes in an institutional setup like Center for Sight or other, there are multiple doctors, multiple people involved, and you may be having a data for a particular procedure for your own cases, but you may, if you include the other doctors, you may get a larger set of patients. However, I don't there is no legal binding on including everybody's name there, as long as you get an institutional okay from the head of the institute or maybe medical superintendent or something to use their data. But what about the ethics of it? Like, if I am using data of 10 other surgeons in the hospital, should I list them all as authors? Will they be defined as guest authors?
Then you should make, I mean, if you use multiple sets of data, then it's a good idea to have a meeting with all of them. And well, of course, there are a number of authors that you can list on a particular paper. The top one, I mean, 5 or 6 contributors can be included as co-authors, provided they also indulge in reviewing your article and then making comments and contributing it, substantially. Rest of them can be acknowledged for their data. There's a limit as to how many authors can be used on a particular article.
I have a question for Dr. Hanawar and Dr. Vanity, your opinions on this. So say, for example, an institute conducts a study, as you said, on a large sample size, right? So there are going to be different studies that can taken out of it, not in the salami slicing manner. But the methodology of the entire study remains the same, because introduction will be different, discussion will be different, results will be different, but how it was carried out remains the same. So is it considered plagiarism, and how should the authors change the content of the methodology? Because it's all about like the same step that has been the steps that have been taken.
Yeah, that should be mentioned in the cover letter that goes to the journal. That
Okay.
well, you have conducted a study, which is a very large study. Methodology is just the same, but the data, aims and objectives, everything is different. Then that should be mentioned very clearly that, well, you have used substantial portions of methodology from a previously published article or a article concurrently under consideration by another journal or the same journal, but everything else is different. If it goes as a even before they consider the article for review, if that is there in the cover letter already, then that's
Okay. So, Dr. Vanity, do you agree? And we don't consider that part as a plagiarism?
See, the methodologies used for arriving at your outcomes could be similar across different studies as well, even if they're done by different group of researchers. Yeah. So I think probably what you're referring to is you're probably publishing the primary outcome of a particular study as one paper, and you're going to publish the secondary outcome as a different paper here. And as Dr. Honawar rightly pointed out that, there should not be a significant overlap, then that goes on as a salami slicing here. So
Right.
it should be clearly, stated that the primary objective, they might be interrelated, but their data is not grossly overlapping. But then the patient subset which you've used would largely be the same. And that's what Dr. Honawar means, like you are appraising the editorial board that the patients are largely the same here. And I think there are several large studies which do talk about, like if you take the MUT trial, the MUT trial is looking at the same subset of patients, but it's a different interpretation. One is giving a completely microbiological interpretation. Another paper talks entirely about the drug interactions, where we are comparing voriconazole versus a standard therapy here. And there's a third paper which talks about the results of surgical or therapeutic keratoplasty. So the data set is relatively the same, but the interpretations or the outcomes which are analyzed are different.
Right. Okay. Thank you for the answers.
So I have a question from the panel. Whether the similarity index and the plagiarism what's the difference between these two? Like, people use these words interchangeably in the world of literature world. So what is your opinion, ma'am? And sir?
they're the same. There's no difference. I don't see there is any difference. Software is listed as different. Similarity index and plagiarism index are the terms that are used by softwares that detect these aspects, but they're essentially the same.
Because some percentage, as a literature says, that some percentage similarity index is allowed, like maybe
It is
10%.
allowed.
15%. Yeah.
Every article, even if you just now sit now and write without referring to anything and write 1,000 words, type in 1,000 words and get it checked, you will have maybe 5% or 10%.
Yes.
That is totally acceptable because these filters are very tight. They even catch phrases of 3 or 4 words, which are very common phrases. You cannot avoid these phrases. So these are acceptable. No journal would catch you for that. When your plagiarism index goes to 30, 40, 50%, they start thinking about it. Review articles, 30% is fine. Original articles, when it touches 20, then there is a matter of concern. And also, it's not just that the numbers they look at. In fact, the softwares underline and highlight parts of the article which are absolutely similar to published articles. Then you look at what those highlighted lines are. Are they just diagnostic criteria or definition of a particular disease, which cannot be, obviously, you cannot change those sentences. These are fixed diagnostic criteria and they are published as such. So if that is the case, then your number drops further.
And to answer Tulika ma'am's question, I think it would be that similarity index is the tool to detect plagiarism. So that is the only difference.
Yeah. Once you're
Thank
doing a plagiarism check, the result comes out as a similarity index. So you have softwares who do the plagiarism check, but when you're looking at your manuscript versus what's available in literature, it says what percentage of what you have written is similar to what is already existing in literature. That's how it is interpreted.
It's a measure of the stealing. How much you have stolen.
Yes.
So any other questions from the audience? I think everything is well answered. So yeah, thank you all for joining us today and for your active participation. We hope the insights shared have been valuable and will help you take actionable steps moving forward. Thank you everyone for joining us.
Thank you.
Yeah.
Thank you and good night.
Good
Thank
night.
you, Very elegantly conducted.
Thank you, sir. Thank you very much.